Hi there everybody, my name's Brodie. I'm an exercise physiologist and I wanted to thank Tracy for organising this conference and inviting me to submit a presentation. I also wanted to thank her for her patience because it's taken me a few days to get this together. So my presentation is going to cover brain health, and it will also introduce you to some of the links between metabolic health and brain health. The start of the presentation includes a little bit of a background of why I've become so interested in the brain after 25 years. So I hope I don't bore you with that. And if you would like to contact me after this presentation, please feel free to email me on brodie@brainfitexercise.com.au. Thank you and enjoy this presentation and enjoy the rest of your conference. Welcome to the Staying Brain Fit presentation, presented by myself, Brodie Cambourne, Accredited Exercise Physiologist. So who am I? I'm an Accredited Exercise Physiologist. I've been working for 25 years in metabolic health, with my first 10 years working with children and parents and babies. For the past 15 years, I've been working in the area of adult health and brain health. And for the past 5 years, I've been working on my own health. I'm an endurance kayak paddler who has been competing using low-carb approaches for the last 4 years. I'm an advocate for the brain at all ages. So my own journey into low-carb started a number of years ago. I'd always been interested in paddling, but about 8 years ago, I decided to extend my distances I was racing. I wanted to do some of the longer marathons that extended over a few days. So I started training harder, longer, increasing the intensity, but I just didn't seem to be losing weight at the same time. I'd just turned over 40 and the weight gain around my middle was starting to worry me. You can see this on the left. So I started to look up some of the better ways to fuel my exercise for these longer races. I'd had heart surgery as a child and I only had one kidney, so I wanted to make sure that doing these longer races wasn't going to damage my future health. It is then that I stumbled across the Tim Noakes story. I started using low-carb approaches to racing. I started winning lots of my races, and I just seemed to have the weight falling off me without trying. So in today's presentation, I'm going to share with you why I love the brain and why the area of brain health has become so important to me as a health professional. I'll also share with you some of the background into insulin resistance in the brain, and also share with you the turning point that made me realise the messages about metabolic health and brain health need to be promoted a little bit more. I'll share with you some research into the areas of metabolic health and brain health, and also a very important area of sleep and brain health. There's also some research I'd like to share with you about the area of metabolic health and Parkinson's disease. And hopefully by the end of this presentation, you'll be able to look at neurological disease through a different lens. So why am I so interested in brain health? For 25 years, I've been working in the area of increasing physical activity for children and their parents. I am the daughter of a professor of language and literacy development and a teacher librarian. So I've always been interested in how the brain learns. So my first 10 years, I was looking at how we could increase learner engagement or children's engagement in physical activity. I wanted children to learn how to enjoy physical activity. And at this stage, I believed that physical activity was the key to weight management for children. I ran a program throughout Australia called the Walk to School program that involved thousands of kids, over 50 schools, 200 volunteers, walking kids to school every day and filling them up with a nutritious breakfast of Wheat Bix. So even back then, I didn't really realise how important diet was to weight management for children. I then went on to run programs for 0 to 5-year-olds and their parents. And this is what led me into working with grandparents and also working with parents with anxiety. The grandparents that would turn up often had injuries or illnesses I needed to be careful of. From there, I started working with neurological health and adults, and I opened the BrainFit gym. BrainFit Exercise Physiology is now running in the Shoalhaven, and at the same time, I started to create the Fiteracy workshops. As I mentioned previously, my father is a professor of language and literacy. Professor Brodie Cambourne created what's called the Cambourne's conditions of learning, which have been used throughout schools all over the world. These 8 conditions of learning are developed based upon how the brain learns best in its natural learning environment. The word Fiteracy is an acronym for each of these 8 letters. I use the Fiteracy program and the conditions of learning when I'm helping my patients learn about neurological health. We have now created what's called the Fiteracy Low Carb page, where we help people to learn more about the applications of low carb for metabolic health. Some of you might not be familiar with what exercise physiology services offer. As an exercise physiologist, we offer exercise prescription for chronic health disease. I've summarised some of the metabolic health conditions I work with at BrainFit. Pain management, type 2 diabetes, fatty liver, hypertension, high cholesterol, prediabetes, impaired glucose tolerance, and hyperinsulinemia. As my business is called BrainFit Exercise Physiology, when I started 9 years ago, I started to get many referrals for neurological conditions. And over the past 9 years, I've seen over 300 people with some of the following conditions: PTSD, anxiety, traumatic brain injury, stroke rehabilitation, mild cognitive impairment, Parkinson's disease, progressive supranuclear palsy, multiple systems atrophy, and multiple sclerosis. I wanted to introduce you to these conditions because we'll be talking about these conditions and the metabolic health conditions throughout the rest of this presentation. So my main role when working with neurological conditions is to provide targeted exercise for the following: falls prevention, general strength, cardiovascular capacity development, exercise for gait maintenance, exercise for range of motion and flexibility, and exercise for social interaction. Our services are very exercise focused. As I learned more about neurological health conditions, I also recognised that exercise was only one pillar of health that needed addressing with these neurological clients. Many of my clients had underlying metabolic health conditions. They were finding it hard to sleep, whether this be due to pain, anxiety, or urinary conditions. Often their nutrition would change due to inability to chew, lack of time to prepare meals, lack of support. Exercise would change due to pain, due to lack of sleep. Stress levels would change due to not being able to understand what was happening with their body from day to day, and also just the stress on the whole family unit many people lived in. So looking at these 5 pillars of health, all of these pillars are very interconnected with neurological clients, but the area that I needed to stay in was the exercise management area. And so I tried to stay in this box for as long as I could. So when I first started working with neurological clients, I was still under the belief that the nutrition guidelines were the way to go. I'd also become very accustomed to just staying in my exercise box. So I didn't want to stray out of that box, as I didn't want to step on any other health professional's feet. So I tried to help my neurological clients with these 5 pillars of health as best I could. So in the area of metabolic health, I provided education on the benefits of exercise for type 2 diabetes, obesity prevention, and hypertension management. In the area of sleep management, I shared information on the benefits of exercise for sleep. In the area of nutrition, I would refer to a dietitian or pull out the recommended guidelines for each condition. In the area of exercise, I felt comfortable. I felt confident I was doing the right thing here. In the area of stress management, I would often refer people to a psychologist or again push home the message that exercise is great for stress management. As I started to look more deeply into the health histories of some clients, I also recognised that many of these people had been living with symptoms and other diagnoses prior to their diagnosis with their current neurological condition. Some of these, and not in any order, included depression and anxiety, metabolic syndrome. Back in the days when metabolic syndrome was mentioned on health histories, sometimes this would accompany a diagnosis of insulin resistance. Often people had been living with hypertension for years or type 2 diabetes. They had been experiencing cardiovascular health issues or had been on pain medications for other related injuries. Once I started noticing some of the metabolic health conditions underlying some of my neurological referrals, I started to become more and more interested in the evidence-based research into the areas of improving metabolic health. My hope was that if we could improve the metabolic health symptoms, then perhaps some of the neurological symptoms might improve. I immersed myself into the world of podcasts and also YouTube and the Diet Doctor webpage. I discovered Dr. George Eade, Professor Tim Noakes, Dr. Peter Attia, Dr. Brett Scher, Dr. Ben Bickman, Dr. Brian and Dr. Tro, Amy Berger, Dr. Paul Mason, Dr. Jamie Seaman, Dr. Paul Salandino, and the two Keto Dudes. I also was very thankful for the people I had close to me. Mrs. Rowena Field, who's a physiotherapist who's studying the effect of nutritional ketosis on pain management, and of course our hero, Miss Jessica Turton, the dietitian who's led the way for us to support low-carb nutrition for some metabolic health conditions. And I also started listening to Tracy's podcast, the Health Evolution podcast. As I immersed myself into hours of podcasts and investigated pages and pages of evidence-based research in the area of metabolic health, I started to become more interested in applying some of this research to my own paddling. I started a low-carb, high-fat approach to the long-distance paddles I was doing. I started on paddling 3 to 5 hours at a time, then extended the low-carb, high-fat approach to paddling 8 hours at a time for 5 days straight. And then one of the last tests I did, I paddled 8 hours a day, eating animal fats only. During these paddles, I got faster and faster as the hours went on. I had no pain and I had enough energy to redo those paddles the next day. Whilst investigating the effects of low carb on my endurance as an endurance athlete, I documented closely how my heart rate was reacting to a low-carb diet over an 8-hour period. I also used continuous glucose monitors to show that my average glucose for 8 hours paddling at a heart rate of 144 beats per minute remained pretty stable between 3 to 5, whilst I was only using 30 grams of carbohydrate per day to last this long. I use this data now to show my clients that if I can paddle at that heart rate for 8 hours at a time, 5 days straight, with no damage, my coronary calcium score has come back normal, my insulin score is at number 2, then surely my clients can walk around, go to work, live their normal daily activities without having to eat excessive carbohydrates. Over time, I recognised the importance of looking at neurological health conditions as many interconnected systems working together. Due to the fact that many of my clients had underlying metabolic health conditions, I found it important to look at the effect of metabolic health on other areas of health. Many of my clients had chronic stress, which in turn increased cortisol release, which in turn increased chronic rises in blood glucose levels, which in turn increased the likelihood of the development of insulin resistance. This then could result in interrupted sleep, which can occur due to rises and falls in blood glucose during sleep times, which in turn results in increased fatigue, making it more difficult to exercise the next day. The lack of exercise often resulted in increased sitting time, which in turn resulted in increased pain. Increased pain often resulted in increased pain medication and increased eating for comfort. Changes in nutrition often resulted in further development of metabolic health conditions, which then in turn resulted in increased stress. I'm an exercise physiologist that works in the enhanced primary care system. The enhanced primary care system offers patients 5 allied health visits per year. These 5 visits need to be spread across all areas of allied health, and often podiatry, physio, and other services will be a priority. Accessing a dietitian may not be a priority. Accessing a dietitian with the latest evidence in metabolic health is also very difficult. How then can we assist our clients and patients to learn more about metabolic and neurological health conditions? So after a few years of listening to hours of evidence-based podcasts, reading many pages of evidence-based research, testing out strategies such as low carb on my own health, asking a few clients to test out a bit of low carb on some of their metabolic health conditions. Some of these clients had great success. I still wasn't confident in promoting this area as part of my business. This was for a few reasons. One, I was frightened. I'm a little bit frightened as an exercise physiologist going out and talking about what we eat and how we sleep is just as important as the amount of exercise we do. 2, I was really frightened of losing referrals from doctors who thought I was stepping outside my box. So I let it lay for a little bit longer. Until in 2019, I had 2 younger clients pass away. It's important to understand that I'd had many older clients pass away over 5 years from debilitating neurological conditions. And as sad as it was these 2 younger ladies that really affected me. They affected me because, looking at their health history, they both had underlying metabolic health conditions. And I wondered if, earlier in their lives, if an intervention had taken place to look at what they eat and how they slept, if their outcomes may have been a little bit better. So this became the turning point for me. I decided it was time to start talking more about the importance of understanding metabolic health. So one of the other reasons I decided it was time to start talking about the links between metabolic health, cardiovascular disease, neurological health, and Alzheimer's disease was that I was starting to suffer compassion fatigue. The effects of secondary trauma of watching some of my lovely clients decline in health over time was starting to take its toll on me. I was finding it hard to go to work and promote exercise alone as this be-all and end-all activity that may improve their lives. It was time to start talking about some of the other strategies they could apply. There had to be more we could do. I still believed in exercise as treatment, and it was still my passion. However, the reality was that exercise alone can only do so much to improve the health outcomes of people with a neurological disorder. What I can say with confidence is that exercise will assist with falls prevention, it will help maintain a social connection with others, it can assist with movement and gait. Aerobic exercise assists with the production of BDNF, brain-derived neurotrophic factor. What I can't say with confidence is that exercise alone will improve your pain. Exercise alone will increase your longevity. Exercise alone will improve your cardiovascular risk factors. and exercise alone will improve your brain health. I needed to let people know that they need to take other lifestyle factors into account. Having dysfunctional metabolic health or metabolic syndrome increases the risk for people to develop other chronic illnesses. These illnesses include neurological disorders, type 2 diabetes, PCOS, liver disease, cancer, stroke, and cardiovascular disease. It's important for people to understand that you can decrease this risk by improving these factors on the left-hand side. It is possible for people to work on their weight. It is possible to work on reversing insulin resistance. It's possible to decrease your blood glucose response to food and stress. You are able to work on improving your hypertension, your triglycerides. You can work on decreasing inflammation and oxidative stress. By improving these factors on the left, you are decreasing the likelihood of you developing these things on the right. Now that it's been recognised that there is a link between metabolic syndrome or dysfunctional metabolic health and the development of neurological disorders, then now we should be able to identify the risks to brain health. By understanding what dysfunctional metabolic health is, we may be able to help people de-risk the development of brain conditions. So metabolic health dysfunction includes the development of insulin resistance, hypertension, obesity, type 2 diabetes, elevated triglycerides. What then affects the development of dysfunctional metabolic health? So metabolic health can become dysfunctional through sleep disturbance, high carbohydrate diets, inactivity, chronic stress, and also the inclusions of inflammatory oils, which we'll see in the next slide. So we have now identified metabolic health dysfunction and 4 of the risks that affect metabolic health dysfunction: sleep, high carbohydrate diet, inactivity, and chronic stress. Now, how do these risks affect our brain? To make it easier to understand, I've broken these into 2 different categories: brain fueling problems and brain cleaning problems. I've also placed these little logos at the bottom of each slide so you can recognise which one is a fueling problem, which one is a cleaning problem. One of my favourite authors and podcasts, a podcast by Dr. Ben Bikman. I often lend his book to my clients, What's Making Us Sick, as it's an easy read for all ages to understand the links between insulin resistance and the development of chronic diseases. So Dr. Ben Bikman, through one of his podcasts, outlines that there are primary causes and secondary causes of insulin resistance. So some of these causes include stress and the elevated cortisol levels. The body will become insulin resistant rapidly with chronic elevation of cortisol and sleep deprivation. Inflammation and autoimmune diseases. The high use of pain medication to combat inflammation is also linked to insulin resistance. Insulin resistance is always accompanied with hyperinsulinemia, which is elevated fasting insulin levels. Also, chronic and frequent consumption of carbohydrates can cause long-term high levels of insulin. Secondary causes of insulin resistance include excessive consumption of linoleic acid, which makes fat cells insulin resistant. Linoleic acid is found in corn oil, soybean oil, and canola oil. So we have identified that insulin resistance contributes to a brain fueling problem. But how can we help clients learn more about what actually insulin resistance is? So insulin resistance is far more complex than what I'm about to explain, but I want my clients to get an idea of why it's important. So I have simplified the story of insulin resistance into simple analogies. The rusty key analogy is one of these. You can see in the white box below that we have a diagram outlining how insulin enters the insulin receptor to allow the insulin receptor to open up the cell to allow glucose to travel into the cell. During high blood sugar events resulting from eating a high carbohydrate diet or events such as chronic stress, the insulin is turning on more often to help move more glucose into cells. The more this key is used, the less effective the receptor becomes, and the channels do not open to allow glucose into the cell to be used as energy. So look at the rusty key on the right. Let's pretend that insulin is the rusty key. The lock is the insulin receptor. The insulin receptor has locked the door. When the key gets turned too much, it becomes ineffective like the rusty key, and therefore the blood sugar is not permitted into the channels. This results in the cells at this receptor site dying. It is this cell death that results in cognitive impairment. So now we know that insulin resistance contributes to cell death in the brain as the insulin receptor site becomes ineffective to the role of insulin. So let's have a look at the brain and where insulin receptor density is the highest. The olfactory bulb, which controls our sense of smell, the hypothalamus, which controls the homeostasis of the body, the hippocampus, which controls learning and memory, the cerebral cortex, which is responsible for attention, perception awareness, thought, memory, language and consciousness, the striatum, which is responsible for coordinating multiple aspects of cognition, including both motor and action planning, decision making, motivation, reinforcement and reward perception, and the cerebellum, which controls motor control, precision and timing of movements. So, as our bodies become more metabolically dysfunctional and we have an increased likelihood of developing insulin resistance, then we have an increased likelihood of cell injury or cell death in these very important areas. So just imagine what it would be like to lose some of these senses, especially learning and memory, as the hippocampus is one of the areas that is affected the most. Another analogy I use to help my clients understand insulin resistance and how a high carbohydrate diet and chronic stress may be increasing the development of insulin resistance is the postman analogy. In this analogy, the postman is delivering blood glucose. The postman meets the receiver at the door to help drop off stores of blood glucose for storage. The postman is delivering blood glucose, the receiver is insulin, finding somewhere to use or store the glucose parcels. After multiple deliveries each day at the door, the receiver gets tired and is unable to get to the door to open it. The result is the postman keeps leaving the parcels at the door or tries to find areas to store these excess parcels. For example, blood glucose getting stored as fat on the liver. At the same time, the receiver calls in more friends to try and help and open the door, but the door still isn't working properly, and all of a sudden we have lots of receivers or high insulin levels. When I talk to my clients about the postman being active because of the blood glucose levels being high from a high carbohydrate diet, I'll often talk about food as fuel. So rather than talk about nutrition, I talk about changing your exercise fuel. So how can we change our exercise fuel to change the energy delivery cycle for better health? So one of the things we can do, thinking of the postman again, is change the size of our blood glucose deliveries, or change the size of the parcels getting delivered. The door is able to open more efficiently because it's not having to deal with a large blood glucose delivery. When the door is open and the blood sugar has been delivered, We can enter ketosis more quickly, and which means that our energy can then be supplied through fat stools also. Exercise helps to keep the door opening by keeping our insulin sensitive. Cells are also supplied adequate energy from both blood glucose and nutritional ketosis. So if we are reducing the size of blood glucose parcels being delivered or the frequency of blood glucose parcels, then many of my clients will ask, but doesn't the brain need carbohydrates to survive? The following information has been adapted from the Diet Doctor website. The Diet Doctor website is a go-to site I use for my clients to access evidence-based videos and resources to help with them making changes to their metabolic health. Although the brain accounts for only 2% of your body weight, your brain consumes 20% of your daily energy. In order to carry out its important functions, the brain requires a steady fuel supply. The brain can use two main fuels, both of which cross the blood-brain barrier. These two fuels are glucose and ketones. When we are not eating a high carbohydrate diet, our liver glycogen is broken down into glucose. After going 24 to 48 hours without any carbohydrates, glycogen levels become depleted and insulin levels then decrease. When our insulin levels are low, the liver produces water-soluble compounds known as ketones, created by the breakdown of fatty acids. The brain always requires some glucose. However, ketones can be used to meet up to 70% of the brain's energy. Gluconeogenesis, making new glucose, enables the brain to use glucose produced by the liver to supply the remaining 30% of fuel required. Let's have a look at problems associated with neurological decline that are related to the brain getting cleaned through sleep. As we've mentioned before, metabolic health can affect our sleep, and sleep can affect our metabolic health. This is why I've made these slides an important part of this presentation also. It's important to understand the impact sleep has on the cleansing process of our brain. So Dr. Matthew Walker has outlined that there are 4 pillars of sleep and that our brain is affected by the dangers of chronic sleep deprivation. He also outlines the important roles of REM versus non-REM sleep, and that these two parts of our sleep contribute to sleep and memory consolidation. He states that human beings are the only species that deliberately deprive themselves of sleep for no apparent reason. Many people walk through their lives in an underslept state, not realizing. He also says that I think sleep may be one of the most significant lifestyle factors that determines your risk ratio for Alzheimer's disease. Several studies have linked sleep disruption to the progression of Alzheimer's disease. Alzheimer's disease has been associated with the buildup of a protein called beta amyloid and tau. An important system to be aware of when learning about brain health is the glymphatic system. The glymphatic system was described and named in 2013 as a system for waste clearance in the central nervous system of vertebrates. The glymphatic system is a network of vessels that clear waste from the central nervous system, mostly during sleep. Recent evidence suggests that the glymphatic system may be disrupted in and contribute to some diseases of the brain. The glymphatic system may be disrupted due to decreased sleep quality and quantity. Metabolic dysfunction can impact sleep through shifting blood glucose levels during sleep, which in turn affects the glymphatic system. The glymphatic system plays a role in clearing out beta amyloid plaques and getting rid of toxic waste. Amyloid deposition is now believed to be a repair component of our brain. An analogy we could use to describe the role of the glymphatic system is of the night cleaners cleaning out a busy hotel or a train station. Amyloid deposition is believed to be a repair component of our brain biochemistry and builds up as a sign that something else is going on. Beta amyloid may be a sign that repair is needed, much like the role of cholesterol is a sign that there is disease in our body. The role of the night cleaner is to clear out these beta amyloid plaques. When we're not getting enough sleep, the night cleaners can't work properly. Successful application of Alzheimer's disease preventative approaches may hinge on an accurate and comprehensive view of other comorbidities such as cardiovascular disease, diabetes, and head trauma. So diabetes is one of the metabolic health problems that may be causing sleep disruption and the build-up of beta amyloid plaques in our brain. Because one of the neurological disorders that I work with at BrainFit is Parkinson's disease, I became very interested in the links between metabolic health and Parkinson's disease. Because many of my Parkinson's clients have disrupted sleep, and some of the Parkinson's clients have developed dementia. I looked at some of these studies that linked metabolic health to Parkinson's disease in an effort to see if we can improve metabolic health outcomes to improve neurological symptoms. Here's one of the studies I looked at. This was a 5-year study. Participants were 40 years plus with no prior diagnosis of Parkinson's disease. Over 8 million men and over 8,900,000 women were chosen. Overall, the individuals who had metabolic syndrome had a 24% higher risk of developing Parkinson's disease than those without metabolic syndrome. Another area to be considered would be looking at insulin resistance and its effect on dopamine in people with Parkinson's disease. There are an increasing number of studies suggesting that insulin resistance negatively impacts dopamine functioning in the brain. Insulin resistance may therefore impact the effectiveness of levodopa as a drug therapy. Insulin resistance is thought to precede the development of type 2 diabetes by 10 to 15 years, and it may be present in PD patients earlier also. PD patients having advance notice of the possibility of insulin resistance in an earlier time could have a great effect on their treatment, as insulin resistance is usually reversible. Another interesting study by Leahy et al. In 2017 in the Journal of Neurology outlined the effect metabolic syndrome has on Parkinson's disease symptoms. In this study, 1,000 individuals with Parkinson's disease were tracked for 3 years. These people were given the United Parkinson's Rating Scale to rate Parkinson's symptoms, and these include measuring motor function, activities of daily living, and reactions to medication changes. The higher the score on the UPRS, the worse the patient is doing. Results showed that over 3 years, those with metabolic syndrome had much more dramatic decline in function and a much more aggressive increase in symptoms. What if we looked at neurological disease through a different lens? Instead of looking at neurological symptoms, why don't we have a look at some of these symptoms as possible symptoms of metabolic dysfunction? Now, in an earlier slide, we had a look at some of the areas in the brain that are most dense with receptor sites, and one of these was the olfactory bulb. What if insulin resistance was contributing to this loss of sense of smell? What if one of the symptoms of Parkinson's, which is sleep problems, was being affected by metabolic dysfunctions and rises in blood glucose throughout the night? What if insulin resistance or metabolic dysfunction or high carbohydrate diets were contributing to gastrointestinal problems such as constipation? And what if insulin resistance or metabolic syndrome symptoms were contributing to the development of depression due to the effect it's having on the dopamine receptor system? Of course, there are other symptoms associated with Parkinson's, such as motor control symptoms and autonomic dysfunction, but the trouble with diagnosing Parkinson's is it's often diagnosed as a large range of symptoms. There is not one set of symptoms that diagnoses people with Parkinson's. If we started looking at some of these symptoms as metabolic and some of them as neurological, then maybe we could start to work on the metabolic symptoms separately. The text in this slide has been adapted from a Parkinson's site called www.epda.eu.com. Now, this site explains that Parkinson's is difficult to diagnose because there is no specific test for the condition. Symptoms vary from person to person, and a number of other illnesses have similar symptoms, which mean misdiagnoses can occur. A possible diagnosis of Parkinson's may be confirmed when other conditions which have similar symptoms have been ruled out, or if the person responds positively to Parkinson's medication. So what if we ruled out some of the symptoms of insulin resistance first? Would this mean that some of these people may not be diagnosed with Parkinson's? So where to from here? So over the last 9 years, now that I've learned about metabolic health, applied it to myself, I have seen others suffer with dysfunctional metabolic health, and I've watched some of my neurological clients decline. I've taken a different step to how I work with neurological clients. So now when I have a client come in with a possible neurological diagnosis who may not have yet started medication, then I'll ask for a health history so we can examine some of the other health problems that may be leading up to this diagnosis. Within this health history, I then help to identify some of the metabolic health systems and ask for recommendations on how, together as a team, we can work on improving the metabolic health of this client. So in this team, I also ask for someone to help with the design of the metabolic health program, such as a dietitian or a health coach. I'll often seek mental health support for this person also through a counsellor or psychologist. I'll assist with the exercise program. I'm lucky enough to have someone like Jessica Turton and her team at Ellipse Health for dietary intervention, and now we're working on sleep management techniques. It's important to understand also that gathering this health history can be easier said than done. Many people will come to their first consult with no health history, but will have a diagnosis of Parkinson's disease or another neurological disorder. Often we need to chase down this health history from their doctors, but often these people are new to the area and have had a new doctor, so their health history is not documented. This can be also very hard for a client who's fatigued and tired, who can't remember back the last 15 years also. We also need to collect current symptoms such as cardiovascular, respiratory, muscular, metabolic, and movement. It's also handy to collect metabolic panels, inflammation panels, liver function, and thyroid function. And just recently, I'm learning more about Dale Bredesen's cognoscopy, which provides a list of health panels to collect for Alzheimer's. So one of the latest things that I'm attempting to do with my clients is create a storyboard of their health data. So you can see on the right here, one of my clients has been collecting her information for over 25 years. She has some thyroid problems, she has inflammation, she has an insulin score of over 35, she's only 36. So this is an area that we're focusing on, trying to work out how her insulin resistance is occurring and how to reverse this insulin resistance for her future health. Her storyboard has made a powerful impact on how we can document this. Through the Fiteracy program online, We're trying to attempt to encourage others to keep a storyboard of their health. And we're hoping this will help with increasing the understanding of metabolic health panels with their pathology, and also understanding their current symptoms.